Hey guys, I'm back. And now this is maternal newborn part 2, labor delivery, postpartum, and a little bit newborn assessment. You ready to have some fun? Let's rock and roll. Okay, so first we'll talk about the stages of labor. So labor is actually divided up into 4 stages. The first stage is the actual onset of labor, when the mucus plug is lost from the cervix gets effaced or thinned out 100%. And then the cervix begins to dilate to a full 10 centimeters to allow that baby to come out. The second stage begins with when that cervix is fully dilated, and it ends when the baby or the neonate is born. The third stage begins after that baby is born and ends when the placenta comes out. And then the fourth stage of labor is basically about 4 hours or so after all of that is done. And, for mom to kind of recover, okay? So when we talk about complications, some things can go wrong, okay? First thing, when you see on TV, the woman's water breaks, gush, there's this big flow of fluid, and then they rush to the hospital. Well, sometimes the amniotic fluid, the sac containing it, does not break on its own, and the doctor or the midwife has to do what's called an amniotomy. And that is rupturing the membranes with a tool. It looks like a crochet hook, actually. It's pretty cool. And they're just going through the cervix and pop and break the water. So if it doesn't break on its own, that's called an amniotomy. Nitrazine strips, something you need to know for the boards possibly. You have a patient, she's 36, 37 weeks pregnant. She comes into the clinic where you're working and complains, I think I'm incontinent. I think I'm dribbling urine. Is it urine, or could it be a slow leak of amniotic fluid? Nitrazine strips are used to dipstick the fluid, and it'll tell you if it's amniotic fluid. So might not be urine. And then induction of labor. So the whole idea of contractions is with every contraction, the baby pushes down, and then the cervix opens up, and to expel that baby from mom's body. Well, sometimes the contractions don't necessarily do what they need to do, or they don't do them as well as they should. So we can actually induce labor. We usually use Pitocin, oxytocin, to induce labor. And what that does is it's a tocolytic drug. And so it stimulates the uterus to contract a little bit more, maybe a little bit harder, right? You would never, ever use Pitocin to induce labor if there were a breech presentation. In other words, the baby is not head down, it's butt down or feet down. If there's any kind of a problem with the placenta, like placenta previa, or God forbid, abruptio placenta, and you have to use it cautiously if mom has hypertension, because that can increase the blood pressure, okay? And so labor, pain management. I have news for everybody. Guess what? Labor hurts a little bit. So there are some non-pharmacological ways to manage pain. We'll talk about them very briefly. The first one is Lamaze breathing. So there was this French obstetrician, Ferdinand Lamaze, and his whole thing is that he focused on different types of breathing methods to help mom cope with the pain. Deep breathing to help with relaxation. Let's say that mom gets the urge to push and it's not time to push yet because she's not fully dilated. Then she can do this panting thing to try to not push, kind of, keep that baby there for a minute until you're fully dilated. Okay, so that's Lamaze. Guided imagery. That's not just used for OB, that's used for lots of other issues with pain. But what it is it's using your imagination. Close your eyes and think about, like, what's your favorite place? Is it a beach, tropical paradise, and imagining yourself there, and that kind of, you escape mentally to that place. Counter pressure. Most women, when they have labor pains, the contractions that cause pain, it's usually abdominal, pelvic, but some women get what we call back labor. So they get a lot of pain in the lumbar area. Sometimes counter pressure can help with low back pain. And it's really simple. All it is dad or the partner is pushing against the lumbar spine. And it's a counter pressure to help with that low back pain. And that really does work. And then last but not least, something called effleurage. Make sure you know that word. Okay, it's important because I know for a fact that are some schools giving tests utilizing things like ATI that they like to ask about effleurage. And what effleurage is light, feathery strokes of the fingers across the abdomen of the mom to like relax mom. Okay, I don't think it works, but that's what effleurage is. Okay, so make sure you know that. Okay, then we can do pharmacological ways to manage pain. The most common is what we call an epidural. Epidural is where they take a needle and go into usually the lumbar spine between vertebrae and put medication in that's like a numbing agent. So it will numb mom from the waist down. So she won't actually feel, she'll feel pressure, but she won't feel pain, you know, from the birth. Takes about 15 minutes or so for it to kick in. And they can put a catheter actually in for continuous pain relief. Okay. And then they can add different meds if they need to. So epidural is the most common. A spinal is a little bit different. It's similar. Still, we go in through, you know, between the vertebrae into the spine, but we're using a little needle, skinny little needle. And it's like one dose, like boom, spinal. There's no catheter, there's no continuous infusion, none of that. Okay, so those are the two most common for labor pain. And then the third thing you need to know about is what's called a pudendal block. What that is a local anesthetic. So in other words, like a lidocaine with a needle into the perineum before they do an episiotomy. And we're going to talk about episiotomy a little bit later. All that is an incision that is made from the vagina to open the vagina up a little bit more to allow that baby to pass and to prevent mom's perineum from tearing. Because if you have jagged edges, they're hard to suture up, as opposed to a nice clean incision, very easy to suture up, right? And less pain. So that's a pudendal block. It's a local anesthetic. There's the episiotomy. Okay, so you can see right there that, you know, the head of the baby coming through the vaginal opening, you know, you're trying to push a watermelon through a straw. And anyway, so sometimes the doctor or the midwife will need to do a little incision, like I said, to help that baby get out a little quicker. Sometimes they'll do it just standard routinely. Sometimes they'll do it because the birth is like imminent. In other words, it's a precipitous birth. That means that mom went, I think I'm in labor. Next thing you know, baby's coming out. Sometimes the baby's head is just a little too big for the vaginal opening, or the baby's in distress. So there are different reasons. The most common is a midline episiotomy, MLE, midline episiotomy. And that's just a midline. In other words, it's a straight line down from the vagina down, not all the way to the anus, but, you know, a little bit there. The other one is a lateral line that kind of across, but either way, they're easier to suture. And, you know, afterwards, they're a little uncomfortable, certainly, but there are things like sitz baths and witch hazel pads that can be used to help relieve the discomfort at the perineal area because of the episiotomy. Okay. Next, now this is important, fetal heart rate monitoring. Okay. So when mom is in labor, with every contraction, okay, the baby's heart rate should accelerate. It shouldn't decelerate, shouldn't go down. Okay. So a lot of different things can go wrong. And, you know, all of them are not necessarily an emergency, but they need to be addressed. So what we do is we monitor mom's contractions and the baby or the fetus's heart rate while mom is in labor. Okay. There are different times where that baby's heart rate can decelerate. And for almost all the time, if there are decelerations, you know, repositioning mom is sometimes an option, administering oxygen, and sometimes it's an emergency and we need a C-section. But how will you remember? I'm going to show you. Okay. You're welcome. So this is an example of fetal heart rate monitoring. So there are 3 examples in this picture. Picture A is, you can see the baby. When you look at the top line is the fetal heart rate. And then the bottom line with the hills and valleys are mom's contractions. Okay. So figure A, what is happening there are early decelerations. When you look at the arrows, and I'm going to put my cursor there, see the arrow? The baby's heart rate is starting to drop right here. And that's right at the beginning of mom's contraction. That's an early deceleration. As opposed to here, the baby's heart rate is starting to drop here. And that's a late deceleration, okay? Because mom's contraction is midway or almost over. And then the last but not least are something called variable decelerations. And what that means is it's just kind of all over the place. So the baby's heart rate is dropping, but it's really not specifically related to the contractions, okay? And there is this cute little thing that you can remember called VEAL chop that will help you remember decelerations and what to do. So if you look at the chart, V stands for variable decelerations, and then the first C in CHOP stands for cord compression. Variable decelerations are usually because of the cord being compressed. And basically you reposition the patient, usually getting mom on her left side, you know, maybe a leg up with a pillow can help relieve the pressure on the cord and stop those decelerations. Then we have E, which is for early decelerations. That can be head compression. So these are happening, they're like a mirror image of the contractions. And because the fetus is lying down in the birth canal, it's causing vagal stimulation, right? The head compression is causing vagal stimulation for the baby, and the baby's heart rate is dropping early on in the contraction. You can reposition mom. They're usually not very dangerous decelerations, but if the baby's head isn't coming through, you know, sometimes the baby just kind of gets stuck. If that's happening, then it might require a cesarean section, okay? Next, the A in VEAL stands for acceleration, and the O in CHOP stands for okay, because accelerations are good. They're reassuring. That means the baby's doing just fine. And then last but not least, the L stands for late decelerations, and then the P in CHOP stands for problem. So late decelerations are a problem. They're usually they start around the onset of the contraction, and then they just drop at the end of the contraction and go down pretty low. And it takes a minute for them to get back up to the baseline or the norm. So that's a problem. You want to get the patient on her left side. That's the first intervention. If that doesn't help, maybe get her on her right side. You want to give mom oxygen right away, usually mask 10 liters. You want to turn up the IV, and usually if she's on Pitocin, stop the Pitocin, because she's probably going to need a cesarean section, you know. So thankfully we have that technology that we can go in and do a C-section and save mom and baby, okay? So fetal heart rate, there you go. Just memorize VEAL chop, and you will not forget what to do depending on what kind of decelerations, if any, mom is having. Real quickly, I just want to go over delivery and positioning of the baby. So right around 20 weeks or so, something, or not 20 weeks, I'm sorry, later on in the pregnancy, right around the 36th to 38th week, something happens, and it's called lightening. And lightening means, ever hear the expression, oh, the baby dropped, now I can breathe? That's what lightening is. It just means that the baby's head descends down into the birth canal, and it feels like this pressure is relieved off the abdomen for mom, because the baby's a little bit lower and getting ready to come out, right? That's normal. You can see the difference here. Here, the baby's up real high, pressing on mom's diaphragm, which is pressing on mom's lungs, probably a lot of heartburn, a lot of shortness of breath. It's uncomfortable. Here, the baby's head has dropped down, right? And it relieves all that pressure up here, okay? And what should it look like for a normal birth? The baby's head should be down, right? Facing mom's back. And the baby's legs and arms should kind of be crossed, like I'm ready, right? That's normal positioning. And, you know, they're occiput anterior and occiput posterior. The best position is cephalic, but sometimes the baby can be head down. And instead of the baby facing mom's back, the baby is facing mom's front. So, I mean, Still okay because the baby's head is down. Harder for the baby's body to manipulate through the pelvis to get out, just a little bit harder. Sometimes they need forceps or a vacuum extractor. It's kind of like a vacuum cleaner, kind of suction on the baby to help the baby get out. But at least the baby's head is down in these positions, right? Then we can talk about breech presentations and then cord prolapse real quickly. When we say the baby's breech, what that means is instead of head down, the baby's butt is down completely, or part of the baby's butt is down completely, or one of the baby's legs is down. I mean, they're all different kinds of breech. I just showed you 3 variations here: complete breech, incomplete breech. See how the baby's one leg is up? Frank breech, both legs are up. Baby's kind of bending himself in half. They don't always require a cesarean, but a lot of times they do. Think about it. If the baby's butt is coming out first, when that baby hits the air, remember, baby while in utero has not been breathing the way we breathe, not that way. So in other words, the umbilical cord, AVA, artery, vein, artery, the umbilical cord is bringing through the placenta, through the cord to the baby oxygen, and then taking carbon dioxide away. So the minute the baby hits the air, all things are normal, baby's going to want to take a breath. Well, if the baby's butt comes out first and the baby's head is still inside mom, baby's going to take a breath of amniotic fluid. So it's usually a cesarean section with a breech presentation. The other complication is what we call a cord prolapse. And what that means is suddenly you see part or all of the umbilical cord hanging out of mom's vagina, right? Oh, right. So there's something called overt prolapse and occult prolapse. So with overt prolapse, the umbilical cord is ahead of the presenting part. With an occult prolapse, it's alongside the baby. So occult, the cord is like right next to the baby's head. With overt, the cord is actually on top the baby's head and coming out the vagina. If there's already complete dilation or dilatation of the cervix, sometimes we can just boom, get that baby out and, no problems. Because if the baby's pressing on the cord, then baby's not getting any oxygen, right? So we don't want the baby to suffer from anoxia. If the dilation is not complete, we're going to have to do an emergency cesarean and get that kid out of there because it's cutting off its own oxygen supply and food supply. Okay. All right. Next, postpartum. So after the baby's out and the placenta is out, mom will have a bloody discharge. It's called lochia rubra. The first couple of days after the baby is born, it's blood. It looks like a period, kind of like a little bit of a heavy period. And then after that, after like day 4, it becomes lochia serosa. So it's a serous sanguineous to serous discharge. It goes on for a few days, sometimes a week or so, week and a half after the baby is born. Postpartum assessment, it consists of assessing the fundus of the uterus, okay? So you should know that about 1 hour after delivery, and it doesn't matter whether it was a cesarean section or whether it was a vaginal birth, about 1 hour after the baby's born, the fundus, which is the top of the uterus, should be firm. It should feel nice and firm. It should be midline and right at the level of the umbilicus. You should be able to feel it right there, okay? The fundus then will, because the uterus should be contracting, and as it contracts, the fundus goes down, down, down. The uterus is trying to get back to its pre-pregnant size, okay? So usually it's about 1 centimeter or 1 finger breadth a day, and you shouldn't be able to palpate the uterus by about 2 weeks after the baby is born. Well, sometimes things can go wrong. What can go wrong? Postpartum hemorrhage. So there are several reasons why it can happen, but for whatever reason it's happening, it can result in severe blood loss, hypovolemia, hypoxemia. The number 1 reason for postpartum hemorrhage is uterine atony. Without tone, okay? So what that means is the uterus gets boggy, it gets mushy because it's not contracting, and that leads to bleeding, okay? So, sometimes it's something as simple as the mom has a full bladder because positionally, the full bladder can be pressing on the uterus and preventing it from contracting. So one of the first interventions, get mom to void, get her to empty her bladder. Sometimes lacerations can occur, cuts. And sometimes if that whole placenta did not come out, if there are any fragments left inside the uterus, they can cause bleeding. And then mom would need what's called a D&C. We used to call that a dusting and cleaning, but really it stands for a dilatation and curettage, which means we would have to go back in, dilate the cervix again, and scrape away whatever fragments are actually left in the uterus to make that bleeding stop. Okay. Now, we can talk about the different ways to assess, but you're assessing that uterus. It should never be boggy. It should never be deviated to the right or left, or it should never be above the umbilicus. Any one or more of those three things can indicate postpartum hemorrhage. Assess the lochia. Is mom bleeding? Is there blood underneath her buttocks? I mean, has she been bleeding and we didn't see it? Get her to empty her bladder, right? We talked about that. If hemorrhage does occur, the classic signs are heart rate goes up and blood pressure goes down. Classic signs of hypovolemic shock coming on, because your body's going, where's our oxygenated blood? And your heart's going, I don't know, let me pump faster and try to get it to who needs it. And there isn't any because you're bleeding, so your blood pressure goes down. Level of consciousness will start to change. She'll start to get confused or, just like pass out. You must massage the fundus firmly while calling for help. Take your hand off the fundus. Help in room 205 or whatever. And she's going to need a tocolytic drug probably, and the drug of choice, methylgonervine. And if she has IV fluids running, wide open, get fluid volume back in to replace the loss of blood. Okay, so that's postpartum hemorrhage. Are you having fun yet? Now, we have a baby, newborn assessment. So once the baby's born, the first thing that they do is suction out the baby's mouth and nose with a bulb syringe and get that baby dried off immediately to prevent hypothermia. Because when you're wet, you get even colder, right? Same with the baby. The newborn is going to receive 2 medications right after delivery. Going to get an IM injection of phytonadione, which is vitamin K, in the vastus lateralis, which is baby's thigh. And that vitamin K, remember, that's the antidote for warfarin, right? That soluble vitamin, it helps blood clot. So it helps to prevent bleeding in the newborn. They have a little tiny liver that's immature, so they don't have any vitamin K stored. So we give them some, help them out. Then the other thing is antibiotic ophthalmic ointment to the eyes, usually erythromycin, but sometimes others. It goes into the conjunctival sac of the eyes to prevent conjunctivitis, because think about where those eyes have just been. And we do an APGAR scoring on the baby. It's done at 1 minute after birth and 5 minutes after birth. And we're going to talk about that next. And it basically assesses the general condition of the newborn, right? So I did include a slide in here about heat loss and the different ways that heat loss can occur. Is it radiant? Is it evaporation, et cetera, et cetera. So you guys can take a look at that on your own. Sometimes the board will ask a question about that, but not common. Oops, go back here. Normal newborn findings. What should a little newborn baby look like? Well, their little hands and feet can look kind of blue, and that's called acrocyanosis. It's normal. Baby can have a fine, downy, soft covering hair all over its body. It's called lanugo, and it's normal, and it's going to fall off in a couple weeks. Okay, sometimes lasts a little longer if the baby's premature. Milia, they're little white bumps, usually on the newborn's nose or chin or on their cheeks. They look like little whiteheads, and they disappear on their own. Couple months. Vernix caseosa is this thick, white, cheese-like coating. It's all over the baby's skin. Think about it. This baby's been floating in amniotic fluid for a long time, 9 months, right? Give or take. And so if you're in a bathtub too long, don't you get all wrinkled? That Vernix caseosa protects baby's skin from that happening. And that washes off with the baby's bath. So these are all normal findings. When we talk about vital signs, normal heart rate for a baby, newborn, 120 to 160, respiratory rate, 40 to 60, systolic blood pressure, somewhere between 60 and 90. Baby's temperature can be anywhere from 97.7 to 99.5. Weight varies. Females like 7.5 pounds or so, 6.5 pounds, up to maybe even 8 pounds. When we talk about a macrosomic baby, that is a baby that is larger than 9 pounds, okay? And usually a macrosomic baby indicates gestational diabetes in mom, and the baby is usually hypoglycemic, but that's going to be the next set of slides, the next PowerPoint. The length can be anywhere from like 20 centimeters, give or take, and the head circumference varies also. I mean, if you're tall, you're probably going to have a taller baby. If you're short, right, you get the idea. But all of these things are, within the normal range. Okay. Here's your APGAR scoring. Okay. 1 minute after birth and 5 minutes after birth. And a normal, I hate the word normal, but a normal score is somewhere between 7 and 10. What that means is that the baby's activity is good, muscle tone is good, right? Their pulse is good, their face, they're are they floppy, or are they like, yeah, why am I out here? That's good sign. What is their appearance? How's their skin color? Are they pink or are they blue? And respirations, so we take all that into consideration. We look at this chart and they come up with a score. If they have a score of 0 to 3, usually you've got a big problem. And 4 to 6 is like, there's a problem. But 7 to 10, all good. All right, so take a look at that scoring chart, so this way you're familiar with that. Fontanelles, these are the soft spots on the baby's head. The top picture represents a normal newborn skull, shows the suture lines. Remember, the baby's skull is in pieces and it doesn't really close for a few months. Why? So it can get through the vagina, right? How's it going to fit through the vajayjay if it's solid as a brick like our skulls are? So we have those soft spots, and they're the areas. There's one right on top of the head, right? Anterior fontanelle. And that's the biggest one. You can actually see it pretty good. There's a posterior fontanelle back by the occipital area, but this anterior fontanelle, this one that's like right on top of the head, can give you a lot of information, right? The fontanelle should be like flush with the baby's scalp. If it's bulging, that can be fluid overload or hydrocephalus, meaning brain filled with water or fluid. If it's sunken, that can mean dehydration. So fontanelles give you a lot of information, okay? And then some other abnormal findings. Remember, 23andMe, 23 sets of chromosomes. The last set is the sex chromosomes, but 1 through 22, each of those are a pair of chromosomes. If there's an extra chromosome, then it's a trisomy. If there's an extra chromosome at level 21, trisomy 21, that's what we call Down syndrome. And I want you to know that the physical manifestations or characteristics of Downs, so that, when you're looking at a newborn baby, it's usually pretty apparent if this child has Down syndrome. So they have epicanthal folds. This is excess skin, kind of like over the middle of the eye. And they have these eyes that are like very almond shaped, right? They're called palebral fissures. The other weird thing is, how we have 3 creases on our palms? Newborns with Downs will have 1 palmar crease on one or both hands. They usually will have a fat, large, wrinkly kind of tongue. It's kind of lack of muscle tone. And when you look at their feet, there is a wide gap between their big toe and the rest of the toes. So there's this wide separation between the great toe and the rest of them. Those are kind of telltale signs of Down's syndrome. Okay. And here's a little chart, give you some more of the physical characteristics. There are others besides the ones I spoke of, but they're all listed in this little chart, and go over them. Then the other thing, which is a terrible thing, is Spina Bifida. So it's a birth defect. So when the baby's in utero and developing, the spinal cord doesn't really develop the right way. And it can be really severe or mild. So there are some pictures here that show you the differences. If you look at the bottom pictures, we'll start with the worst one, myelomeningocele. A myelomeningocele is a sac of fluid. It can be anywhere. It's usually at the base of the spine, but it can be anywhere on the spine. And in it are part of the meninges and spinal cord from, of the baby. That is very, very critical. It's going to need to be surgically repaired. It is important that the parents know to maintain the integrity of that sac. Don't touch it, because if it breaks, inside is the spinal cord. So this baby can be paralyzed, right? It's a myelomeningocele. A meningocele, same kind of sac, except the spinal cord is not in it. It's just the meninges, not quite as critical. And then there are other kinds of defects that can occur. Some of them are really, really frightening. When we look at cephalies, when we talk about the word encephaly, we're talking about damage to the brain. So anencephaly, the brain is just open. There's no skull, right? Encephalocele, part of the brain is herniated, usually at the base. It's scary to see. And then anencephaly, it can be usually the base of the skull, occipital skull defects. And usually the head is really, really small or oddly shaped. Okay, so these are all things that can go wrong, sadly. And thankfully, they're not common. Okay. And then here I go through the pictures again of the different types of spina bifida. And here's some actual photographs. Let's try to move out of your way, so you can take a look at what they look like on a real newborn. Maintain the integrity of that sac. The parents need to know that, so that there is no damage to that spinal cord. And then one more thing I want to talk about, again, not common, but it happens, and it's something called hypospadias. Hypospadias is in a male newborn where the penis, while it's forming, there's a malformation of it, and the urethra, instead of opening up at the tip, right? This is a normal penis. The urethra is at the tip of the penis. The urethra opens up somewhere on the underside or the bottom of the penis. And it can be anywhere from like right around there, all the way up towards the testicles. And that's a problem. This is going to require surgical repair. If the child has hypospadias, circumcision is usually delayed because they're going to use that foreskin to help with the repair of the penis when they fix that urethra. Okay. And that's really all you need to know about hypospadias. And that also is not a common thing. And that's it for part 2. I'll drop the mic. Boom. If you have questions, you know how to get a hold of me. Remember, subscribe to my channel, like it. I'm counting on you. All right, guys, until next time. See ya.